Good afternoon. Thank you, Madam Chair. It is a privilege to be here with you. I will, as Victoria mentioned, I will introduce a little bit the perspective of WHO. I wanted to share with you the global health agenda has put people-centered health systems in top of our national and international agenda. In particular, in our region, the Health 2020, in view of these global commitments, the regional office, in agreement also with the member states, launches the development of a framework for action. Basically, rather than a strategy that will be done at global level, the regional office will concentrate mostly in an operational aspect of integrated and coordinated care. As we said, our focus is mainly on operational perspective. The other aim of developing this framework for action at the regional level was to better define what it's meant by people-centered health systems. And here I would like to recall a little bit the topic of your Congress, that is patient-centered or patient orientation. And we do distinguish in WHO between these different perspectives. We want to think that there is a patient perspective that is related to a more disease component. There is an aspect that is related to person perspective, which is considering, yes, the perspective but of the patient or the individual, but also from a health perspective, and therefore all the preventive and promotive measures or initiatives that we take in preventing diseases and promoting health are also included. And finally, there is a people perspective, which also includes that the group of individual. It means a population-based approach to health. One of the aspects, as I mentioned, is to keep it simple, but to keep it also focused on the actions. And I think you have already heard from the keynotes this morning, but I understood also from the minister the need to think in terms of initiatives that are expanded or are scaled up at a higher level. Volker also this morning showed a slide where if you look into the initiatives that we undertake from, triggered perhaps by fundings, this usually has a lifespan that lasts 3-5 years, and then many of those are fall into non-action. So we are interested to look why some of the initiatives can scale up or do scale up and others don't. We use, perhaps I don't go into details now, but just to recognize in this graph that the fact that, of course, we talk about people, and when we talk about people, we want to acknowledge that there are components or the interface between the people and the health systems is the services, the provision of the services themselves. So we do acknowledge that there is, it is hard to talk global or comprehensive health systems if we don't consider that there is an intermediate, conceptually at least, an intermediate function that is related to the provision of services. I can come back on that definitely later on. And of course, there are aspects related to other sectors that recognize that the determinants of health has roots not only on the health sector, and that we can only cope with a certain type of diseases or individuals, but the roots of other aspects of health, let's think to smoking, to healthy lifestyle, are definitely to be sought also outside the health sector. So when we talk about people, we want basically at least to think to two key aspects of those people. One is related to the empowerment of people, and here we are thinking to the capacity or to the activities that are related to make sure that people live healthy lifestyles, eat healthy, take care of all the prevention and promotion of their own health. And these are clearly, there are clear strategies defined, and this is one aspect that at least we need to consider when we talk about patient and when we talk about people in the language of WHO. And there is also another aspect that is a little bit more peculiar, that is the one related to engagement. And in this case, we want to think how people or how patients are engaged, for example, in their discharging plans, or how do they follow up treatments to avoid dropouts, or how they self-medicate, and so on. So I think it's a very rough distinction, but those imply at least different types of interventions and strategies that we need to deploy to make sure that we talk about people-centered. As I said, there is then the aspect related to the procurement of services, to the provision of services of health, and here perhaps I will not go too much into details, but we need to consider that there are aspects related to different procedures that we take in place. We select services, we define pathways, we organize the providers to make sure that there is continuity of care or integration of care. We manage the resources, but we also put in place mechanisms to ensure that there are continuous improvement of the performance of the providers. And this is related to the topic of quality. Definitely quality is linked to this continuous improvement of the performance. But then there are aspects that are related to the health systems in general, and we have to acknowledge that there are at least aspects related to the accountability of the providers, of the network of the providers, how those mechanisms are put in place, what is the role of the insurance or the purchasers in general, and so on. Same-wise related to the financing of the system, how the providers are paid, but what mechanisms and incentives are put in place to make sure that we achieve this quality and people-centeredness. Competencies relate here to the aspect of human resource for health, and while you look in the green part of the graph, you may think to how, for example, nurses or doctors communicate with their patients. On the blue part, we want to make sure that the number of health professionals or physicians are matching the needs of those people. What competency, what skills needs to be developed. And here we think also to the undergraduates, for example. This is a system issue. The fact that, as was mentioned by the minister, we have an average age of 50-something or 60 in our physicians. It is an aspect that relates to the system. We do not expect that the providers will deliver or procure services, taking this into account. This is a given for the providers. From the system perspective, this is something that we can change, but it requires, of course, time and other type of deployment of strategies. And in this sense, this distinction already puts you gives you a bit of a clue when we talk about initiatives that are looking into integration of care. Usually that lifespan of 3 or 5 years is related to this distinction. In 3 or 5 years, I can change the green part of the graph. I can modify the services that I'm provided. I can change the pathways if I want to put a care manager, for example, to take care of the patient. What it is more difficult is to change the blue part of the graph. That will require 5, 10 years of work, very much policy and advocacy and political support to change those parts of the system. And that is perhaps a reflections that we need to take into account when we think to scale up the initiatives in integrated care. I will, well, for this reason, we have already started a process of defining a conceptual framework for the integrated services delivery, but also we are collecting information or initiatives from member states, and we will publish that soon later this year. And we accompany also all this work with the change management manual, that we hope also to identify this type of tips or the provided tips for scaling up initiatives. We do this with a huge network of stakeholders and partners. We do have, we have collected initiatives around Europe, and we are now working on coming up with the common lessons that we have in the region. But let's think also to the lack of integration of or e-card, for example, here in Germany, and we can also acknowledge that there are barriers that are system barriers and definitely disincentives for change. And basically it puts in comparison 3 experiences in 3 countries. One is Germany, of course, and this is the healthy kissing valley. Then in the Netherlands, the aspect related to bundle payment. And then in England, some of the integrated care pilots. And this is not an evaluation, it's not the same methodology applied through all the cases, but these experiences has been evaluated from outcome perspective or intermediate indicators, and finally in cost. And it is very interesting to see that the first case in Germany, it's a population-based approach, and it has immediately a very clear outcome related to 2.5 years after enrollment of life gained. And this has been, you can see in the article, it has been also, or in the evaluation actually, that even adjusted by some confounders arrives to 1.7, so it still is a clear indication that the people enrolled in the programs are better off than those ones that are not. There is also a cost saving, which is what you see in the last column of this graph. When you look to the bundle payment system of the Netherlands, which is only targeting diabetes and hypertension, then you do see an improvement, of course, but you see also an increase in the cost. It's almost $388. This is another study that we are conducting here in Germany, but this part of the study relates to ambulatory care sensitive conditions or hospitalization here in Germany. The 2 graphs are, the red one is for women and blue for men, standardized standardized hospitalization rates, and for 22 conditions that are sensitive conditions to ambulatory care, which basically means there are conditions for which someone has been hospitalized and there was not, we could have been prevented if well treated in the ambulatory care. And here, the reflection, I can go into more details, but the time does not allow it. Yes, this is known to the German system, and there has been some initiatives put in place to tackle this issue. And I'm thinking, for example, to the local and regional physician networks. There are 400 already here in Germany, and also to the filial Praxen and Zweigerpraxen. I'm sorry for the pronunciation, the very German pronunciation. but I wanted to share basically these are initiatives that also has been experienced in other countries. I will not go into details, but France definitely is a very similar case to the one I just mentioned here. Some of them, as I told you, we have many others. Norway, for example, also have put in place. Another strategy that Germany is using is to expand the role of the physician assistant, and we have the physician assistant 2, more as a care managers, coordinators. At the moment there are, I think, 5,000 in training, and this is something that has been already applied in other countries. So it's not only the German case, and of course the role of our organization is to bring the member states together to take common lessons in terms of implementation, but also in terms of those tools and those specificities that are peculiar to each country. Thank you so much.